part 2 of lecture 15. We're going to move on from Alzheimer's related neurocognitive disorders and talk about some of the other more common types of neurocognitive disorder and a few rare ones as well. So, as I mentioned before, it's hard to definitively know exactly which types of neurocognitive disorders or dementias are out there because some of the diagnostic processes are quite complex, including the conversation we had a moment ago about diagnosing Alzheimer's via autopsy definitively. All that being taken with a grain of salt then about the epidemiological breakdown of which dementias are caused by what, it's quite clear that vascular neurocognitive disorder, aka vascular dementia, is a very common, most likely the second common form of neurocognitive disorder. So a vascular dementia is related to any sort of blocked or damaged blood vessels that affect the brain. As I said, it's generally regarded as the second leading cause of neurocognitive disorder. And the onset, unlike in Alzheimer's, is often sudden because there's some sort of insult to the brain. That is not entirely the case in every situation. There are plenty of medical conditions that over time contribute to vascular damage in a more gradual fashion, especially things like high blood pressure and diabetes. The patterns of impairment in neurocognitive disorder are highly variable, like the way that it presents itself and which types of symptoms manifest, because if you remember from some of our early discussions in this class, the areas of the brain are localized. And so wherever that stroke or aneurysm or blood vessel damage tends to be in the brain, that's where you're going to manifest the deficits. So if you, for example, have a left-sided stroke on the left side of the brain, which is largely involved in our language abilities, it's very common to see things like aphasias or difficulty with speech. There's expressive and receptive aphasias. There's very different types. If a person has damage to, say, the cerebellum of the brain, then you might see some smooth motor coordination or some motor deficits. If it's the right side of the brain, you might see some impairment in spatial reasoning, visuospatial abilities. Frontal lobe of the brain, you might see some impairment in judgment and impulse control. So wherever the damage is, that's related to where the deficits are going to emerge. So that being said, the patterns are variable in that expression. They are also extremely variable in terms of course and onset. So when I talk to patients about dementia, I will sometimes draw them a little rough graph on a piece of paper. And on one of those graphs on the X and Y axis, there's sort of this line going down at a steady slope. And I usually use that as an example of how Alzheimer's progresses. Depending on the individual and depending on the case, and perhaps when the Alzheimer's developed, the steepness of that slope is varied, but the consistency of it does not change. It is always progressing. It's always getting worse. Whereas a vascular dementia, we might visualize as being a series of stepwise deficits. So each of those steps, they can be big steps or small steps, are related to various damage to the brain due to, cardiovascular blood vessel reasons. So for example, a major stroke might have the person coming along at their baseline and then a major step down related to their stroke and the damage that it causes. There'll be a period of another plateau beginning beneath that. For some people, especially those that address some health issues that are able enough or fortunate and lucky enough to not have another stroke, to not have another major insult to the brain, they may stay on that new plateau for many years. They may not show lots of progressive deficits. For other people with vascular dementias, there is a series of steps. And as you pull the camera focus back away from that series of steps, it looks very similar to an Alzheimer's course, right? But what you're not seeing is those individual insults or individual episodes, for example, of high blood pressure or hypertension. You might see episodes of very high blood sugars that are being poorly managed in diabetes, and therefore episodes of damage to the brain because of hyperglycemia. So there is a different course than we typically associate with Alzheimer's, but in some cases they can be very similar upon appearance, even though the underlying etiology or the cause is different. Needless to say, though, most cases that will meet the diagnostic criteria for a neurocognitive disorder will eventually require some degree of formal care in the later stages as they do show progression over time. I would say it's the more abnormal example of someone who has sort of a single incident and then nothing else happens for the rest of their lives, say. That being said, vascular dementias are quite common. And what I usually say as a rule of thumb, if you're working in a clinical setting, if you see spotty deficits, if a person is doing, normal or above normal functioning in certain domains, but they have this like one or two specific areas of significant impairment, you want to start thinking about the possibility there's been some vascular damage. So the cognitive disturbances themselves, the deficits are identical to other types of dementias, to Alzheimer's. There are typically signs of neurological damage to the brain tissue that can be detected through a variety of imaging. The prevalence rates are about 1.5 for people 70 to 75, but about 15% for people over 80. So as you can see, very common type of dementia. The risk is slightly higher in men, although it's not clear why that is. It may certainly be related to lifestyle issues or willingness to seek medical treatment for chronic conditions that can be managed that might relate to that, rather than something that's actually due to the person's biological sex. Frontotemporal neurocognitive disorder, aka frontotemporal dementia, or FTD, is another form of neurocognitive disorder that's quite common. It's probably the third or fourth most common. Frontotemporal dementia, I would say, is kind of the dark horse of the dementia world, in that it is not nearly as well understood as, for example, vascular or Alzheimer's disease. It broadly refers to some sort of damage to the frontal or temporal regions of the brain. And if you remember from previous discussions, the frontal lobe of the brain is the seat of consciousness in some ways. It is the civilizing part of our brain. It is our inhibitory control. It has a lot to do with our personality. And it also has a lot to do with our behavior because of that inhibitory control process. It also is involved in language to a certain extent as well. So there are two types of impairment we typically see associated with frontotemporal neurocognitive disorder. One is sort of a precipitous decline in language. The person begins speaking less and less and less, or they might start to show difficulties in the expression of language. So they might start to misuse certain grammatical rules, or have difficulty with word finding, for example, is a very common complaint amongst patients that I see. But there's also a behavioral syndrome that's associated with frontotemporal dementias, and that behavioral syndrome can be quite dramatic. I'm thinking of a couple of cases that I've seen, one in particular of a guy that was former Special Forces in Vietnam, but also was very accomplished upon coming home from Vietnam, very successful business person, and then started developing frontotemporal dementia. And his behavior changed dramatically. He became very aggressive. There were some episodes of violence towards the end of his life. He would say like particularly cruel or sort of hateful things to his loved ones, which by all accounts was uncharacteristic of him at other points in his life. He also would make a lot of inappropriate sexual comments to female providers. Just all loss of inhibitory control in a lot of cases with this person. And that's sort of the behavioral pattern we associate with frontotemporal dementia sometimes. One example of frontotemporal dementia is Pick's disease. And it usually involves a rather precipitous decline in one of these two areas as well. So Pick's disease itself is a relatively rare neurological condition, and it accounts for about 5% of all dementia diagnoses. It produces what's called a cortical dementia, which is similar to what we see with Alzheimer's disease. So it's one of these situations where there might be a relatively common amount of, there might be more Pick's disease out there than we think that's being diagnosed as Alzheimer's. But according to researchers, it does represent a separate process or a separate etiology. Little is known about what causes Pick's disease, though. And so it's relatively unknown, but it's a subtype of frontotemporal dementia. But there's still a lot to be discovered about it. So, of course, as we mentioned about vascular dementia, you've got these cardiovascular processes like strokes and aneurysms and, anything relating to blood flow to the brain, or, which essentially is, not just cutting off blood flow to the brain because blood does not cross the blood-brain barrier. The job that blood is really doing, as it is for all of our tissue, but especially critically in the case of our brain, is delivering oxygen. So when you have a burst blood vessel, for example, you've got an aneurysm in the brain. Blood is actually poison to brain tissue. I shouldn't say poison, it's toxic to brain tissue, which is why there is the blood-brain barrier in the human body. So that's an example of where blood is actually released into the brain. But typically what we're talking about with vascular dementias is a blood flow issue that causes cell death due to anoxia, due to a lack of oxygen to certain neurons in the brain. Of course, another way to result in damage to brain tissue is through a traumatic brain injury of some kind. So accidents are the leading cause of these traumatic brain injuries. However, I work in the VA, and so I am unfortunately very familiar, not as much in my practice with older people, but there was a massive, massive discussion that sort of ran parallel to the understanding of traumatic brain injury in contact sports that was going on in the VA, and the reason why is because it's twofold. One is that there was a in between, let's say, Vietnam and what are called the OEF, OIF, the wars in Afghanistan and Iraq, respectively. Those wars, the ability to save people on the ground, right? People who are critically injured, to get them life flighted out of those situations and to a major, medical trauma center was incredible at how quickly they were able to do that. And the ability of paramedics and other medical staff and corpsmen and medics in the field to stabilize people and keep them alive has gotten better and better, and the equipment has gotten better. So what we saw in those more recent conflicts was people that were surviving serious injuries who would have otherwise probably died en route to getting critical care that could save their life. At one time, I remember hearing that, if you were injured in Afghanistan or Iraq, you could be at a tier 1 incredible trauma center at Ramstein or Landstuhl in Germany, within a few hours, as fast as they could get you there on a plane. Essentially, they could get you out of the combat zone very quickly. So what you have is people surviving very serious physically traumatic injuries that would have otherwise resulted in mortality. So you have that factor, and then what you also have is that if you look at Vietnam, sort of the primary way in which people were getting badly injured was often through gunshot wounds. Now, of course, there were certainly booby traps and other types of artillery and explosions and things like that. If you look at the more recent conflicts, what is the sort of the quintessential thing we think of in Afghanistan and Iraq during those conflicts is the IED, the improvised explosive device. So a lot of people experiencing close-up contact with explosions, including all of the concussive force that comes with an explosion. It is a perfect recipe for damaging tissue, including brain tissue. So you combine this increased exposure to concussion, concussion in terms of the physics, but also concussion of the brain, coupled with people surviving really serious injuries, and what you get is an epidemic of TBI. It's something that receives a lot of funding and a lot of research and a lot of attention within the VA. Parallel to that, as I mentioned, we had a new understanding about traumatic brain injury related to contact sports, especially, of course, in football. That's been sort of the crux of a lot of the conversation. So TBI, or traumatic brain injury, however it's arrived at, whether it's through combat exposure or through an accident or through contact sports of some kind, is that the person experiences some sort of head injury. And in doing so, they cause damage to the brain. So the symptoms have to last for at least 1 week after head injury, and they typically have to involve some problems with executive functioning, learning, or memory. Memory loss is the most common symptom. What's a little different about this is that it essentially, it can look, in some cases, very much like vascular dementia, but having a traumatic brain injury, especially a more global traumatic brain injury, presents with a slightly different feel when you're assessing the person. It can be more global, it can be more specific depending on the type of injuries the person is sustaining. And then, of course, we have this conversation about CTE, right, or chronic traumatic encephalopathy. And this is the idea that it's not about someone sustaining necessarily one really big, major concussive traumatic brain injury. It's about a progressive brain condition that's caused by repeated blows to the head and repeated episodes of mild to moderate to even sometimes severe concussion. So it's particularly associated with things like boxing, American football, And most of the studies and research that's done on CTE is done on athletes. The idea being it's not about someone who's in the Army or the Marines, boots on the ground in Iraq, and experiences a major concussive force once. It's about repeated head injury over time that can produce similar effects. So, as we said, it's very commonly found in athletes who experience repeated blows to the head. It's certainly commonly found in veterans who've been exposed to explosions or other concussive forces. And it is, like I said, it can have a lot of the same similar manifestations and characteristics as vascular dementias, meaning it can affect virtually any part of the brain. Another area that I feel is, somewhat understudied and is interesting. I see a fair amount of this in my practice as well. Is this is the mouthful term, neurocognitive disorder due to Lewy body disease, aka Lewy body dementia. So let's define that term first. Lewy bodies are these microscopic protein deposits that damage the brain over time, and the symptoms tend to have a gradual onset. We're going to talk about dementia or neurocognitive disorder due to Parkinson's disease in the next slide. Now, this is one of those areas where I think the research is still out. There is a lot of confusion about Lewy body dementia and Parkinson's disease essentially being overlapping parts of a Venn diagram. It is very common to see a Lewy body dementia in someone who also has Parkinson's disease. That being said, not every person who has Parkinson's disease develops any cognitive impairment or dementia. So there are related concepts. We believe that the Lewy body impairment is also affecting dopaminergic pathways in the brain specifically, but it takes a rather interesting course in some people. Let me give you a little anecdotal evidence about this. When you start to see enough Lewy body dementia, you become familiar with the symptoms, and certain themes, certain conversations start to get repetitive with multiple patients. So when I started learning about it, what I learned was that one of the sort of keystone or characteristic distinguishing symptoms of Lewy body dementia is early onset visual hallucinations. So there are some potential hallucinations associated with all forms of dementia, especially those that affect visual pathways in the brain. Some people with Alzheimer's disease in the severe stages will report hallucinations. It's not that uncommon. What's weird is someone who is largely cognitively intact, maybe having some mild deficits to begin with, but all of a sudden starts developing visual hallucinations. What's even weirder about this condition is that in most cases, this is anecdotal, but the research will back this up to a certain extent, those hallucinations tend to fit a pattern. They tend to be relatively pleasant, first of all. They're not always terribly frightening hallucinations. And what's weird is this theme. Patients with Lewy body dementia tend to report that what they see is small children or small animals, often people of one age or another, often physical forms of people. There's no auditory component. These are purely visual hallucinations. And I just started hearing this over and over and over the years with dementia patients. And it got to the point where I would be talking to a patient and we would get to some questions about their cognitive status, and they would get a little quiet, or they'd get reluctant, or maybe their spouse would speak up and they would say, well, tell them about the things you've been seeing. And the person will say, well, I've been having some hallucinations, or I've been seeing some things that aren't there. Now, if I already know that patient has Parkinson's disease, or if I suspect they do, I will sometimes say, let me ask you a question. Did you see little children or little animals that were kind of non-threatening? And the person will look at me like I'm psychic, right? And be very confused as to why I knew to ask that question. It's not that I'm psychic or that I'm a genius in this area. It's that this is just simply the way this disease tends to manifest itself. So I've just had, I wouldn't say countless, but I've had lots and lots of patients over the last 15 years or so who will say, I saw little kids at the foot of my bed, and when I would try to talk to them, they would run away, or I would look outside in the yard and I would see, little squirrels or little animals that I knew were not real because they didn't seem to have the weight of something real, or I pointed them out to my family member and they didn't see the animal. But it's a weird manifestation. That being said, other symptoms that are typical of Lewy body disease or Lewy body dementia are right up there in the common categories of other dementia symptoms. So things like impaired attention, concentration, and motor impairment issues. So that motor impairment issue, which Can happen with Alzheimer's, can also happen with vascular dementias, of course, can happen with frontotemporal dementias. But there seems to be some connection between the motor impairment process and Parkinson's so that it looks very similar. So you see things like tremors or freezing that are associated. That being said, let's move on and talk about specifically Parkinson's disease for one moment. So Parkinson's disease, as many of you know, is a degenerative brain disorder. It is chronic and progressive and currently has no cure. I think most people's exposure to Parkinson's disease might be through the activism of the actor Michael J. Fox, who very famously came out publicly many years ago about his Parkinson's diagnosis, and has done a lot to raise money for Parkinson's research with his foundation. So Parkinson's disease involves dopamine pathways in the brain, specifically something called the nigrostriatal complex. And that part of the brain is involved in movement of the body and our motor activity. Some estimates say that 1 out of 1,000 people are affected worldwide by Parkinson's disease. This is not an uncommon illness. The chief difficulty, of course, is motor problems, tremors, postures, difficulty with walking, difficulty with speech. So people with Parkinson's might be tremulous, they might shake, have what's called an essential tremor or a Parkinsonian tremor. They may also experience what's called cataplexy or freezing, where the person seems like they can't move at all. They're kind of stuck in a position. So that's another symptom associated with it. Often they have trouble with mobility and they may develop speech difficulty as well. That being said, not everyone who has Parkinson's disease develops dementia, and about 75% of people who are diagnosed with Parkinson's survive 10 plus years after the diagnosis. So while it is a progressive illness, it tends to not progress rapidly. Parkinson's tends to be a more dangerous, fatal illness for those that develop it when they're older and already have a lot of other health issues on board. So let's talk a little bit about some of the specific neurocognitive disorders related to HIV and AIDS. So we know that as HIV progresses into AIDS, or as HIV infection goes on in the body, it can cause neurological impairments, and eventually the person may meet criteria for a dementia. It's usually associated with a lot of the attention concentration aspects of the brain. People will report they have a hard time focusing, or they might start showing what's called cognitive slowness. So their reaction time and their processing speed will slow down. There's often a lot of apathy and social withdrawal associated with this. And this is not just due to the illness and, of course, in certain situations, especially in the past, social stigma. Rather, the person is sort of displaying difficulty with planning and execution, executive functioning type things that leads to the person appearing kind of apathetic and withdrawn. It tends to occur in the later disease stages of HIV/AIDS, and what we're really fortunate is that it now occurs in less than 10% of individuals who have HIV, and that is entirely due to the development of the HART medications, the HART regimen of medications. HART stands for highly active antiretroviral therapies. This is the so-called AIDS cocktail or HIV cocktail of drugs that were developed several years ago and that have continued to be refined and developed to the point that we are able to, even people who will continue to be HIV positive, we can significantly delay or completely prevent the development of the actual AIDS, I shouldn't say the AIDS syndrome because the S in AIDS stands for syndrome, but you know what I mean, for progressing from HIV into full-blown AIDS. So as a result of those highly effective medications, mortality rates for HIV and AIDS have gone up and up and up the mortality rates have gone down, the survival rates have gone up and up and up. And a lot of people are avoiding these worse symptoms and the death associated, of course, with progression of the illness. Huntington's disease is a relatively rare genetic autosomal dominant disorder. It's caused by a very specific gene on chromosome 4. So we've talked before in the past about things being polygenetic, multiple genes contributing to things like alcoholism or depression or even schizophrenia. Huntington's disease is one of those rare conditions, sort of like Down syndrome, where there is a very specific monogenetic cause. As I may have mentioned before, if you have a parent, a biological parent who has Huntington's disease, you have a 50% chance of developing Huntington's disease. And they have developed a test which can determine whether or not you are going to develop Huntington's prior to the manifestation of symptoms. I shouldn't say going to develop. They can determine whether or not you have that gene on chromosome 4, which in most people means you're going to develop symptoms. It manifests itself as involuntary limb movements, which is also called chorea. So this disease, you may see it written as Huntington's chorea. This is common later in life. About 20 to 80% of people who have Huntington's will eventually display some neurocognitive disorder as well. And the dementia follows what's called a subcortical pattern. So let me take a moment to sort of explain the difference between cortical and subcortical. Cortical, if you think about the cerebral cortex of the brain, cortical dementias are things typically like Alzheimer's disease. We mentioned vascular dementias can be both, depending on where the damage is. Frontotemporal tends to be cortical. Lewy body presents in kind of a mixed pattern, but cortical dementias tend to affect things like aphasia, agnosia, forgetting things, apraxia, difficulty coordinating movements. Subcortical syndromes involve less severe intellectual and memory dysfunction. So they tend to be a little, typically, I should say, less severe in the manifestation of those kind of classic dementia symptoms of forgetfulness and intellectual dysfunction. Prion disease is a rare form of dementia as well. And it's related to, it's a disorder of proteins in the brain that they reproduce, and by virtue of that unchecked reproduction cause damage to brain tissue. There is no known treatment for Prion's disease, and it is always fatal, unfortunately. The good news is that it tends to affect only 1 out of 1 million persons. So if you are fortunate enough not to be that 1 out of 1 million, you can sleep at night not worrying about Prion's disease necessarily. It is, interestingly enough, only acquired through cannibalism or accidental transmission. So you have to essentially consume contaminated blood or get it transfused into your body somehow. So Creutzfeldt-Jakob disease is one example of prion disease as well. It is linked to mad cow disease. So this is really about an illness that creates a reproduction of these proteins that are deposited in the brain, and by virtue of those deposits cause damage that eventually becomes fatal. One of the last ones we're going to talk about is substance medication-induced neurocognitive disorder. So most obviously the thing that we probably discussed, just because of the prevalence of its use, is heavy alcohol users and how this can lead to various types of dementias. There are a couple of examples of this. There is the two that are most commonly discussed is one called Korsakoff syndrome. These are both named after physicians that helped to discover them. Korsakoff syndrome and Wernicke's encephalopathy is the other big one. Encephalopathy is associated with swelling of the brain, which then causes damage as it presses against the inside of the brain lining, or the skull lining, excuse me. 50 to 70% of chronic heavy alcohol users will show some degree of cognitive impairment. It may not reach the threshold of being neurocognitive disorder, but they will have some degree of impairment. They may be able to adapt and function. 7% of those will then go on to meet the criteria for neurocognitive disorder. So it's resulting from prolonged drug use, especially coupled with some of the lifestyle issues associated with really bad chronic alcoholism or drug use, things like poor diet, poor self-care, and hygiene. It can be caused, though, by alcohol, sedatives, hypnotics, anxiolytic, inhalant drugs. I've had one patient that I've worked with in the past who had a manifestation of this due to inhalants, due to sniffing. I believe in his case, I believe it was spray paint after he left the military. But alcohol is the most common one that we think of. And so essentially this is permanent brain damage caused by extremely heavy drug consumption. The symptoms are very similar to Alzheimer's. The deficits may include memory impairment, aphasia, apraxia, agnosia, disturbed executive functioning, which, remember, is sort of like the higher functioning of the brain associated with the frontal lobe. I had an experience when I was an intern. My mentor, Larry Weinberger at the New Jersey VA, took me to see a patient along with the patient's primary care provider, and they were talking about this. This guy was in the ER. They knew him very well. They'd known him for years. He was a very heavy alcoholic for many, many years, and he had pronounced, alcohol-induced neurocognitive disorder. So he was presenting with some odd blood work in the lab, and they were talking about this patient in front of this patient. And to my untrained eye and ears, I felt like it was insensitive. They were being very explicit, and they were talking about, oh, well, it could be this, and well, if that's the case, then we'd have to think about chemotherapy. I mean, they were basically saying, well, he might have cancer, and he might have this, and he might have that, and I was just kind of shocked by it. And afterwards, I remembered, I kind of noticed the patient was showing very little emotional reactivity to this information. He was just kind of saying, okay, all right, and kind of going along with it, but did not seem disturbed or distressed. They came up with a plan of care. They explained to the patient, here's what we're going to do. We're going to send you down to the lab and get some additional tests, and then we'll follow up with you. The guy left the room, and I said, gosh, Larry, that was kind of harsh. What were what's going on? And he said, Mark, I know this patient really well. He has pronounced Korsakoff syndrome. He has basically a lack of affect associated. He has no emotional reaction to things you discuss. And more importantly, he will not remember a single word we said the minute he walks out this door. And lo and behold, I was able to interact with that patient a little more down the road, and he basically introduced himself to me every single time he met me. So as I was trying to monitor his condition, I realized very quickly that psychotherapy was not going to be helpful for this guy because he could not retain information, period. It was really pronounced. So, this is a specific type of dementia which is induced by lifestyle and can be really associated with heavy drug consumption of various types, but most commonly alcohol. So we're going to talk a little bit about the etiology of neurocognitive disorders. Now, by defining some of these disorders, I've talked about the etiology by default. For example, vascular dementias, right? The etiology is you have a stroke, you have unchecked blood pressure, unchecked diabetes, traumatic brain injury. The etiology is the brain injury itself that causes the dementia. So we're going to talk about Alzheimer's disease because A, it is the most common type of dementia, and B, because we have a lot of research and a pretty solid understanding of at least what's going on, if not why, in the brains of people with Alzheimer's disease. So there usually are two factors or two characteristics we associate with Alzheimer's disease that are seen upon forensic study of the brains of people with Alzheimer's. So typically you'll hear this referred to as tangles and plaques is how I was always taught. So they call them neurofibrillary tangles. These are strand-like filaments throughout the brain that develop that then will damage brain tissue and therefore damage the ability of neurons to communicate. And then you also see what are called amyloid plaques. These are essentially like fatty deposits within the brain between the neurons. And essentially, if you think about it, if you have a synapse between two neurons, and the synapse is that space between the dendrite and the axon that they communicate across what's called the synaptic cleft in between those two neurons. That's where the electrochemical transmission takes place. So one neuron releases neurotransmitters, for example, into that cleft. The other neuron receives that at the axon terminal. I'm sorry, the dendrite. I'm getting it backwards. Anyway, it's received by the other neuron, and that causes an electrochemical impulse in that neuron. It fires, and therefore it is able to send the message down the chain, whatever that message might be. In Alzheimer's patients, those plaques develop, and they sort of glom all over those neurons, and they essentially are flooding that synaptic cleft with this gummy deposit that basically inhibits the ability of neurons to communicate. It's like if you had two electrical wires that were both hot and you suddenly poured a puddle of water in the middle, they're just going to continue to fire, or they're going to basically overheat at some point. So the brain of Alzheimer's patients tend to atrophy because our brains go through a process called dendritic pruning or neural pruning that basically it's use it or lose it in your brain. If you have parts of your brain that you don't use, those parts tend to atrophy and tend to have cell death, and cells die off in those areas. One of the most classic examples is what's called infantile amnesia. This is not so much atrophy as it is brain development, but if you have children, or if you've ever been around children as they're young, as they grow up, what you find is that As they develop language, the part of their brain that was storing memories pre-language, that was very sensory, was probably much more based on visual imagery or feel or smell or anything, other senses besides language. Those memories go away. And it's really shocking as a parent, where you have a kid who, for example, like we used to sing a certain song with my daughter at bedtime all the time, and then we didn't sing it for a little while and just kind of moved on to other things. And then a year or two later, when she was 4 or 5, we were talking about it, and she was like, I don't remember that song. I've never heard that song. And it was just shocking to us that she had lost it. But that's part of that process. So the memory centers of the brain that we have when we're very young basically get pruned away and are replaced by a language-based memory system. This is just an example of how areas in the brain that are not used, they tend to atrophy. And because of these plaques and these tangles, those parts of those neurons are not firing effectively and therefore tend to atrophy and shrink, which is why you see physical differences in the brains of individuals with Alzheimer's versus those without under things like PET scans. We know that multiple genes are involved in Alzheimer's disease, so it is polygenetic. It includes genes on chromosomes 21, 19, 14, and 12. Chromosome 14 is associated with sort of the subtype, if you will, of early onset Alzheimer's. Chromosome 19 is associated with later onset Alzheimer's. Just anecdotally, in my experience, if you develop Alzheimer's in the sort of early onset pattern that happens to some people in 40s and 50s and early 60s sometimes, there is a stronger genetic evidence that this is passed on in families, that it's more hereditary than other forms of Alzheimer's, than late onset. And it tends to be more aggressive. It tends to progress faster. I have a colleague whose husband in his maybe mid to late 50s developed early onset Alzheimer's, and within 3 to 4 years was requiring full-term care. It was really rapid. Chromosome 19, as I mentioned, is associated with the more common late onset Alzheimer's, which typically develops in the 70s, 80s, and 90s. So there are two ways in which our genetics can lead us to potentially cause neurocognitive disorders like Alzheimer's in particular. So there's what are called deterministic and susceptibility genes. So these are the rare genes that inevitably lead to Alzheimer's. This is the strong heritability side of Alzheimer's. There's one called the beta amyloid precursor gene, which means that you are more prone to creating those amyloid plaques in the brain, which cause the damage. There's also what's called presenilin 1 and presenilin 2 genes that are associated with determining whether or not someone will develop Alzheimer's. There are other genes within the brain which are called susceptibility genes, which you might think of as being synonymous with the earlier concept of diathesis, right? Remember, a diathesis is not necessarily going to express itself absent the appropriate stress. That's the diathesis stress model. So susceptibility genes being present in an individual are not deterministic. They don't mean that that person is absolutely, inevitably going to have Alzheimer's. It may mean they are more prone to it under the right circumstances and the right stress. This is an example from your book of a susceptibility gene, which is called ApoE4. It's located on chromosome 19, and it's associated, as I said, with the late onset Alzheimer's. So among Alzheimer's patients, it is more prevalent in those who have a family history of the disease, indicating that there seems to be some heritability, some genetic factor in Alzheimer's. So it's more likely to produce a cognitive decline in the context of a stressful environment. This is the gene environment or diathesis stress model we've talked about. So there are several psychosocial factors and physiological factors associated with the causes of neurocognitive disorders. There is a link with high blood pressure. This is most likely going to be more associated with vascular dementias, of course, because high blood pressure puts you at risk for things like cardiac arrest, stroke, all these cardiovascular problems that can go wrong. It also sometimes goes hand in hand with cardiopulmonary or respiratory problems, and that can also reduce the flow of oxygen to the brain as well. So, if you have your cardiac or your pulmonary system or both not functioning correctly, those are different pathways to end up with damage to the neurological tissue. But psychosocial factors don't cause dementia directly. We know that they are associated with varying degrees of stress, and so as you increase psychosocial stressors, you may influence the onset and the course of the illness. Drug use, diet, exercise, stress, these are all examples of both positive and negative potential impacts. There are certain risk factors which seem to be culturally associated, so they vary by ethnicity and class, but there's limited influence in this case. While there does seem to be some of these things that are correlated, the causality of them is certainly not clear. Educational attainment, coping skills, social support, these are considered protective factors for dementia. We've talked a little bit earlier in this first part of this lecture about psychosocial factors like educational attainment maybe being a protective factor against dementia, meaning that people with educational attainment, which is also correlated with increased IQ, so we might actually be measuring intellectual ability as opposed to, how many letters you have after your name. But what we're really getting at is you have this pre-morbid intelligence that allows you to adapt and cope longer than someone who doesn't, and therefore the symptoms are staved off or the functioning is not impaired as soon. What we have noticed, though, is that it's sort of like a rubber band. When you stress those protective factors long enough, people who maybe are staving off the obvious onset of the illness or they're adapting, once they reach the limits of that adaptability, tend to progress a little faster and catch up with their peers. Coping skills, of course, are important in a whole host of psychological diagnoses. Having healthy coping skills is a way to, try and stave off a lot of things, including, it seems, based on the research, the onset of dementia. And social support. Now, there's mixed evidence about whether or not isolation causes dementia or social withdrawal causes it. And from my experience, anecdotally, it certainly exacerbates it and makes it worse. There are a few primary treatments available for all the various types of neurocognitive disorders we've discussed. Most treatments that are out there are attempts to slow the progression of the deterioration, but they cannot stop it. So there are a series of drugs that are on the market right now, what are called cholinesterase inhibitors. So Aricept, Exelon, Rimonil, memantine, galantamine, these are all various drugs that are on the market. They are only FDA approved for mild to moderate stages of dementia. So these are drugs that you use early in the process of the person's dementia. They have really very limited, if any, efficacy once things have already advanced. When I talk to patients about these, I've consulted with my clinical pharmacist that I work with to make sure that I'm not, talking outside of my area of understanding. But this is what they've told me, and this has been consistent with my experience in this job, is that people that are started on these drugs are often very upset to find out they have dementia, and they are eager to get anything and everything that we can give them to help with this condition. What I always tell patients, because I want them to have an honest understanding of what's happening, is I say, none of these drugs, even the makers of these drugs, claim that they will stop or cure dementia. They don't do that, right? They're unwilling to make that claim because they can't. Best case scenario, it's like applying the brake a little bit along the way. So the progression is slower. You might be taking the slope of that line and making it a little less severe, but it does not by any means stop the process. Basically, if you think about the very first drugs that we had for depression, the very first drugs we had for pain, when they're in their infancy, they're not terribly effective. And these are first, arguably maybe second generation anti-dementia drugs. They are not by any means a magic bullet that's going to fix everything. So while they are out there, they have limited efficacy. And for some people, I'm not sure they make a huge amount of difference, at least in my experience. There are, of course, tons and tons of areas of fascinating research about things we could do to try and treat or potentially even prevent and or reverse Alzheimer's disease. So there are things like glial cell-derived neurotrophic factors, there's stem cells, tons of stem cell research on Alzheimer's. But essentially, I think until we can somehow turn off the body's production of the factors that lead to the amyloid plaques, that lead to those those dendritic bundles, those fiber bundles, it's going to be really impossible to cure this illness. If we could somehow communicate with the body on a cellular level or on a neurochemical level to stop the production of those damaging factors in Alzheimer's, well, then now we're talking about the possibility of a cure. We are not there yet, unfortunately. As I said, there are lots and lots of exploratory things, and unfortunately, there are lots of things out there that claim to do things they don't. Ginkgo biloba is mixed findings. Ginkgo biloba as a dietary supplement to improve memory, by no means a cure or a preventative cure for Alzheimer's or other types of dementias, but many people swear by it. But of course, people swear by a lot of placebos, unfortunately. But if it works for you, I don't want to take that away from you. But just don't present it as a cure. There are some drugs that are utilized with dementia patients to treat the associated symptoms. It's very, very common for people with dementia to have comorbid depression and anxiety. So we often will start people with dementia, if they are depressed or anxious, on antidepressants, anti-anxiety medications, keeping in mind that as dementia gets worse, anti-anxiety medications like the benzodiazepines can actually make confusion worse. They have a weird effect on people with dementia, so they are not always the best choice. The other medications that are typically associated with dementia are what are called the atypical antipsychotics for agitation. This is a good example of treating the symptom, not the cause. As people progress within dementia, they often will start to have periods of extreme agitation, especially as the day goes on. There's a phenomenon called sundowning that's associated with dementia, and that is where the person is largely lucid, more cognitively intact early in the day, but as it gets dark and later in the day, and more likely they get tired and fatigued, they start to suddenly display qualitatively different and worse levels of functioning cognitively, and one of the things we associate with this is agitation. So clinically, the term agitation is someone who is animated, upset, they may be angry, they may be fearful, but they're really in this sort of accelerated or excited state psychologically. They can get really defensive, they can lash out and hurt other people or themselves accidentally. They can have certainly falls or other types of accidents when they're agitated. And they can occasionally, be aggressive or threatening to other people as well. They may just lash out defensively. They may just hurt somebody out of a lack of inhibitory control. So the treatment for that is the use of these types of medications. Now, the medications are not stopping the dementia process. What they're doing is sedating the person. But what we found, and they're calming them down a little bit, what we found, though, is that these atypical antipsychotics work much better than the anti-anxiety medications like the benzodiazepines, which can sometimes make agitation worse. There are some very, very fascinating potential treatments associated with these things, including vaccines. I talked a little bit previously about how the messenger RNA, the mRNA vaccine technology that's behind the Pfizer and Moderna COVID vaccines has nearly unlimited application to other conditions as well. So some of the really cool sort of bleeding edge research we're seeing now is the idea of vaccinating people against Alzheimer's disease or other forms of dementia, which is kind of fascinating. So these are things to look for on the horizon, especially as we have this demographic bump of more and more people living longer in a graying population. Slightly, we have lowering birth rates in a lot of countries, especially in the West. And so we're going to have an increasingly older population, which means an increasing likelihood and increasing prevalence of dementias, and therefore the need is going to only grow. Many of my colleagues, myself included, but I have some colleagues in the geropsych world at the VA who work a lot with how can we intervene behaviorally, psychologically, to help dementia patients to improve their quality of life, to reduce the severity or the impact of symptoms. So the aims of these treatments are really trying to enhance the lives of the patient and their families. You teach people compensatory skills in the early stages of dementia. You got this wonderful little computer in your pocket if you have a cell phone, and you can utilize it for things like reminders. You can use the calendar or the lists that are built into those devices, or do it old school analog, and you can put a little book in your pocket and carry a pencil, and you can write things down. So there are ways, especially early on, to try and compensate a little bit. Reminders help, signs in the home, that kind of thing. There are some various types of behavioral interventions that are called memory enhancement devices. So people can carry like little wallets with themselves or books that have all these details about themselves, and they can act as a reinforcer to try and help that person hold on to some of that information. Um, Cognitive stimulation does seem to delay the onset of more severe symptoms. So it's not clear if being isolated or being unstimulated is making the dementia worse, but we do know that if you get people a little more engaged and you get them interested in something to engage their mind, engage the brain, it seems to delay the progression of the illness to getting more severe in the later stages. A really big part of my job, and one of the ways in which psychologists treat, I'm putting that in air quotes, dementia, is to work with the families and caregivers of those that have it. If you think about modern psychotherapy, so much of it is based upon providing information, helping the person practice various techniques to change their way of thinking, for lack of a better term. And if you don't remember what we talked about in the previous session, the minute you walk out of my office or the minute I leave your house in home-based primary care, then you really can't engage with psychotherapy in that way. If you're not able to engage the executive functioning abstraction part of your brain to connect to some of the concepts that we're discussing in therapy, then therapy is not going to be effective. So the ability that I have, excuse me, the ability that I have to engage a person with dementia with psychotherapy, it gets worse. It diminishes as their dementia gets worse. In the early stages, there's definitely some utility for psychotherapy, but certainly by the time someone's in moderate to severe stages of dementia, there's not a lot to be done from my discipline's perspective for that individual. Where you can be very, very effective is to work with the social support network around that individual. And I do a lot of work with the spouses, family members, and other caregivers of patients with dementia. First and foremost is empowering them with information, educating them about the disease that they are dealing with, so that they know what to expect, so they know what things are. There's a wonderful book out there called The 36-Hour Day, which I utilize with patients all the time, and they're mostly with caregivers. And it's really about it's like an almanac of dementia, but also has a lot of information specifically for caregivers. So it's a great resource, but it also has some powerful anecdotal experiences and things that can help the person to feel less alone in this role as a caregiver. When people progress in dementia, they often engage in a lot of problematic behaviors, things that can really put them in danger or just, create stress. They are prone to wandering. So sometimes we utilize things like what are called wander guards, which is essentially like a low jack that you might see on someone who's on house arrest, but they've gotten much smaller and much less obtrusive. So a way that if the person does wander, at the very least, we can either get alerted that they've crossed the threshold of the home, or if they leave the house and wander off, we can hopefully work with law enforcement and other resources to find them and keep them safe. There's also a lot of socially inappropriate behavior with people that are dealing with dementia. It might be, taking your clothes off in a public setting and exposing yourself because you're not really thinking about the implications of that. It might be sexually inappropriate comments or, other offensive statements where the person's frontal lobe is not inhibiting that behavior as much. So working with caregivers of how do you respond? Like, do you get angry or do you ignore it? Do you redirect? Like, what are you supposed to do to be most effective? And we help them develop strategies for dealing with those behaviors and also dealing with aggressive agitation, rebellious behavior. And then, part of the conversation with every single caregiver I talk to is I have to emphasize the importance of self-care. That, being a sole caregiver for a person with advanced dementia is not a one-person job. It's 24/7, especially if that person is displaying sleep impairment. A lot of dementia patients develop what's called day-night reversal, where they convert to being nocturnal. So they are up all night and sleeping all during the day, which is not very conducive for that caregiver to meet their daily needs and do the things they need to do. They get to the point where they can't leave that person alone without assistance. And so they start to neglect important things, including their own medical appointments or getting their prescriptions filled. So a big part of my work with caregivers is checking in with them on self-care. And sometimes for very selfless caregivers, people that are very dedicated to their loved ones, you have to explain, look, I understand that you want to do everything you can to care for this individual who's vulnerable, but if you don't take care of yourself, what's going to happen to them? So sometimes that's the way you connect and you help them to relate to the importance of self-care. So they may need their own education and support, caregiver support, but they also may need their own mental health treatment, because it's extremely depressing and anxiety provoking to witness a loved one going through this process. So oftentimes we really want to focus on those collaterals and those people surrounding the person with dementia and make sure that we're helping that network as well. So there are some things that we can try to do to prevent neurocognitive disorders in older people. There's some mixed evidence about the use of anti-inflammatory medications being helpful. There's been some limited evidence of correlation between the use of things like ibuprofen or Advil and reduced risks for the development of neurocognitive disorders. That being said, please don't go start taking 8 or 10 Advil every day because you'll burn a hole in your stomach. That's one of the bad things about chronic use of those drugs. Of course, a lot of the things are just related to the health psychology world, right? We want to try and encourage healthy behavior and healthy lifestyle. So smoking, heavy drinking, leading an active social life and not being isolated, these are all things you can do to try and prevent the development of neurocognitive disorders. Other targets of prevention are often focused on just trying to minimize harm, what's called harm reduction models. A big part of people with dementia is frequent falling due to poor judgment or to some motor deficits, some actual neurological motor deficits secondary to the dementia. And so a bad fall is often what either causes or begins the spiral of medical decline that leads to a person's death in old age. And so trying to increase safety behaviors to reduce the likelihood of a serious head trauma, for example, is one thing we can do with older people, but also something we can do with young people to try and prevent things like traumatic brain injury. So this is where the conversation surrounding how appropriate is it for young developing brains to be playing contact sports comes in, right? When I was a child, if you'd asked me if I was going to let my kids play football, I would probably say, yeah, of course, what they want to. It's not my thing, but okay. Now I would have a really hard time allowing my child to play football, but not just football. I don't want to just demonize football. It's really a lot of other contact sports. There's a surprisingly convincing research out there about even soccer, because of the likelihood of accidental collisions going for headers and things can lead to some problems as well, especially as the brain's developing. Certainly it's true in a lot of other sports like boxing and MMA. It's pretty patently obvious why that would be the case. So, encouraging people to wear bike helmets, to wear, to improve the technology of the helmets and pads that are used in football. All of these things to just try and prevent trauma to the head. Certainly there's been a massive amount of development in things like body armor, including helmets for people in the military and for people who are helicopter pilots, race car drivers, all those things. If you look at sort of the helmets that are worn by F1 drivers now, then they're probably multi-$100,000 helmets, just by virtue of all the technology built in to try and protect this relatively fragile bit of tissue up here in our skull. Excuse me. Reducing your exposure to neurotoxins and the use of other drugs can also be a preventative effort to prevent the development of dementia later in life. So let's summarize a little bit about this chapter. Cognitive disorders are broad. There's lots of different types and ranges of deficits that you can see in the various types of neurocognitive disorder. So attention, memory, language, motor behavior, anything that your brain does and controls in your body, which is everything beginning with regulation of body temperature, your blood pressure, your heart rate, all the way up to your ability to understand the books written by some of these guys over here on my philosophy, shelf. So being able to really abstract and perhaps understand Nietzsche or Aristotle, everything in between those things, those are all things your brain does, right? So anywhere that your brain has a function, an insult or damage of some form or another to that part of the brain can therefore result in a related deficit. So there is no one single symptom we associate with dementia. And we've kind of gotten away from this misconception that memory is always a part of the picture. I've it definitely is in a lot of people. It's sometimes the most obvious manifestation, but coming to realize that even the change of the diagnosis in the DSM-5 no longer specifies that one of those cognitive domains where there's significant impairment has to be memory. At this point, it can be any of those major cognitive domains. The causes are associated with a number of things, most importantly, of course, with aging. The older you get, especially if you live into your 70s, 80s, and 90s, the increasing prevalence of dementias goes up quite a bit. There are certain medical conditions, of course, which are specifically associated with dementias. Anything that puts you at risk for vascular damage, high blood pressure, diabetes, stroke, heart attack, but then, of course, Parkinson's disease, Huntington's chorea, all those things. Abnormal brain structures, of course, can be related to the causes. So we mentioned the amyloid plaques and the fiber bundles that happen with Alzheimer's, as an example. Drug use, and then environmental pollutants. One of the things that's been in the news a lot is, of course, a lot of areas that have these, ancient, poorly developed infrastructure for water that have lead in their pipes. Well, lead causes a lot of brain damage, and so there's any time you're exposed to chemical byproducts or pollutants, things that can cause damage to the brain, you're increasing the risk as well for dementias. Regardless of what the type is or what the specific manifestation is, by definition, these neurocognitive disorders, outside of delirium, which remember is acute and often reversible, but whenever we talk about the minor and the major neurocognitive disorders, what we're referring to really is a chronic progressive condition. That is the key characteristic of this illness. So almost all of them result in some progressive deterioration in functioning. As I mentioned, there are some less common examples of things like a single vascular insult to the brain, like a major stroke, and then let's say that person really kind of gets very good about taking care of themselves, advocating for their recovery. They change their lifestyle, they change their diet, they really pay close attention to all those factors, and they never have another stroke. They reduce their blood pressure, they bring their cholesterol down, they do all the things you're supposed to do after you've had an experience like that, and they may kind of plateau out and stay right there for the rest of their life. There are few treatments that exist, unfortunately, to reverse the damage and the deficits. The limited treatments that we have, at best, slow or stall the progression of these illnesses. And unfortunately, that's the state of the science right now. That's where we're at. Prevention is really the name of the game as best we can. And of course, funding and supporting lots and lots of well-conducted research to try and develop techniques that actually really do treat these conditions. And at this point, there's not a lot out there, unfortunately, and it's going to affect more and more people. So this is research that we need to be focusing on quite a bit.